So just to get started, I want to say, as social scientists committed to understanding the complexities of human societies, it's important to begin by acknowledging the land that which we gather. The University of Toronto operates on the traditional territory of many Indigenous nations, including the Huron-Wendat, the Seneca, and most recently the Mississauga of the Credit. The land has been a site of human activity, governance, knowledge exchange, and cultural expression for thousands of years. It remains home to many Indigenous people from across Turtle Island, and we recognize the enduring presence and resilience of First Nations, Inuit, and Métis communities. As we engage in scholarly inquiry, let us reflect on the responsibilities we carry as researchers, educators, and community members to respect Indigenous knowledge systems, histories, and rights.
Welcome everyone to the Reframing Pain Conference. I cannot tell you how thrilled I am to have this day finally arrive. At this particular historical moment, I think it's more important than ever for us to gather together in the work that we do toward equity, toward social justice, and be able to support each other. So PEPR is the project from which CASPR emanates. So PEPR has two main objectives. The first is to bring an equity lens into this notion of patient engagement and research, and to really explore both what that does look like and what it could look like. And then the second objective, which relates directly to CASPR, is that we have a mission to advance critical social science approaches in the chronic pain and pain research spaces. We are inter and multidisciplinary. We have anthropology, we have sociology, we have nursing, philosophy, occupational therapy, physiotherapy, psychology, social work. You name it. The disciplines, I think, are represented through CASPR. So thank you so much, everyone, for being here, and thank you to all the speakers who've traveled so far to join us today.
Some years ago, I was kind of casting around for what my next research project was going to be, and I started talking really very casually at first to some of my clinician colleagues about pain. And almost right away, I got these really strong reactions, these kind of charged stories that felt like they were just pouring out of them. They would say things like, "Ugh, pain patients, I want to turn and run when I see one coming," or "Pain, whew, that's the thing that can still make me sweat." Or, "Man, I just get a knot of fear in my gut when I know it's a back pain guy coming up." They would also talk a lot about feeling like they had been tricked, about, as they sometimes put it, getting burned, talk about how it had changed their practice after the first time a patient stole their prescription pad or turned out to be selling the pills they prescribed. That is to say, when I brought up pain, what clinicians often offered up were pretty explicitly and pointedly stories not about patient pain at all. And as an anthropologist, my attention really got caught by all this frustration and angst and sometimes even straight up anger that I was hearing, coming from clinicians who I also knew to be very caring, deeply committed healthcare providers. Caught too, by the way, it seemed like there was this kind of eagerness, urgency, and need to talk about this, these pouring forth of stories. And also by the deeply embodied ways that these clinicians were often expressing their experiences with pain patients. Juggling. This is a familiar, with a slight twist, figure I'm gonna imagine to many people. The sickening anger, the sweaty anxiety, the knot of fear in the gut, indeed the very notion of getting burned, right? The force and the specificity of that metaphorically but powerfully embodied language kind of emanating from clinicians, I found it compelling and also deeply concerning. It seemed clear to me from the very start that clinical interactions around pain were not just emotionally charged, but relationally fraught. And a word I think we're going to hear a lot of echoes of that today, probably, in ways that seemed clearly harmful, right? Harmful to the patients who were subject to these negative reactions, but harmful also to the clinicians themselves who are expressing and experiencing this level of really distancing discomfort and distress. And I should say by relationally fraught, what I mean is the way this clinician language seemed to highlight a sense of themselves as so personally implicated entangled, affected, even maybe endangered sometimes by their interactions with pain patients. This seemed to me kind of distinctive and about something more or different than just that question of uncertainty, that pain's infamous subjectivity, which we'll also be talking much more about, that pain so often seems to raise for medicine. The tension here seemed much more around what the philosopher Elaine Scarry has famously described as the problem, or it's not about that problem of doubt in pain, of the way having pain can be to have certainty, while hearing about it can be to have doubt. More at issue here seemed instead something like what the anthropologist Vina Das highlights as the kind of back and forth, the mutually constitutive dynamics of pain as making a claim that's asking for acknowledgement. So I was kind of animated by those early experiences, and I turned to ethnography to try to study in a fine-grained way what happens observably and in real time on the ground in clinician interactions around pain, to study, that is, the sociality of pain in the US context. And for this group, I'm sure I don't have to belabor too much what ethnography is. There's tons more I could say here, but this is just a very kind of quick and dirty of my IRB-approved methods. And what I want to do is just offer two brief kind of contrasting ethnographic moments as I hope a sort of illustration of what close attention to those on-the-ground social dynamics of clinician-patient interactions might contribute to the broader conversations we're having today. So, Dr. S. I'm shadowing Dr. S through a busy day in her primary care clinic. She's an experienced and deeply kind clinician, white, late 30s, has a bustling, sort of generally warm manner. We move smoothly through the routine choreography of the first few patients, and it's unusual when she pauses outside the next exam room door, kind of takes a deep breath, rolls and then squares her shoulders, gives me a quick wincing glance and says, "Back pain, here we go." She knocks on, then opens the door, moving quickly through introductions and toward the computer desk in the corner of the room. The patient, who I'll call Mr. K, is white-haired and angular in his late 60s with watery blue eyes. He's perched anxiously, hands kind of clenched tightly together on the edge of his metal chair. Dr. S sits down, facing the computer screen, gets down to business right away. The opening questions, the easy banter I've observed with other patients is pretty markedly absent this time. She launches in, already tapping on the keyboard. So, nothing new going on, really, right? Just time for some refills today, yes? Mr. K starts to say, sort of hesitantly, yes, but Dr. S keeps going, shifting into a tone of voice that sounds almost as if she's speaking to herself as she moves through the electronic chart. Looks like your blood pressure's doing okay, no need to tweak anything there. In similar fashion, she works pretty quickly through the rest of the medication list, asking a terse question here or there. There's a low-dose prescription for tramadol that's among those, and confirming that he'll be due for blood work next time. And then with an unmistakable sense of closure, she stands and turns to face Mr. K directly as she asks, "Okay, so anything else you wanted to talk about today?" Mr. K leans forward in his chair, words coming out in an urgent rush as he says, "My back, really, some days I'm just knocked flat. It's not getting any better. Is this just it? Is that really, isn't there?" Before he can fully finish, Dr. S breaks in. "You know, we've done the testing we can do. You've seen all the specialists by now, and really, I think this is just going to be something you have to work with." Mr. K opens his mouth again, but before he can say anything else, Dr. S rolls on. "And I know we've talked about more pain medicine, but really, we're already doing what we can safely with you. Anything stronger, look, that's just not a path I can go down." Softening slightly as she moves toward the door, she adds, nearly talking over her shoulder now, "I wish this were easier, but keep up with the NSAIDs, with that stretching I gave you, got the tramadol when you really need it, and I'll see you next time." With that, we're out the door, and in the hallway, she kind of pauses again, gives me a rueful glance, and says, "Not what you're used to with me back there, right?" And she's right. That interaction was markedly different, colder, faster, more aloof from others I'd observed with her. Acknowledging her own unease, she continues, "It's tough, really. It pains me. But when there's nothing you can do, gotta kind of steel your backbone as soon as you go in. Keep it moving. You just can't get sucked into all that." The distinctive microdynamics of that encounter really stayed with me. The squared shoulders before entering, the turned back during most of the appointment, the relentlessly forward motion of Dr. S kind of plowing through the encounter, leaving so little room for anything at all from Mr. K. And her own language, too, voicing again that embodied expression, steely backbone, preemptive pulling back from not getting sucked in, but also a sense of futility and discomfiting failure when there's nothing you can do, and it pains me. Dr. H. So Dr. H, white, early 60s, is one of the most seasoned clinicians in his primary care group. He's barrel-chested and quick to laugh. He starts each clinical day at the computer, reviewing the patients on deck, jotting notes to himself, sometimes offering brief asides to me as he goes. He says with a shake of his head, we've got Mr. G in today. Long history with this guy, all kinds of pain stuff, shoulder, neck, spine. He's bounced around like a pinball, gesturing at a long list of specialty consults. Not much I can do for him at this point. He trails off with a shrug and pushes away from the desk, and we're off to see the first patient of the day. We come to Mr. G last, a strikingly tall white man in his 40s. He sits carefully folded onto one of the metal chairs when we enter, offering a tight smile as Dr. H swings a chair around to face him. He sits and asks, so where are we today? Tell me what's been going on. Mr. G walks through the state of his various pain sites, gesturing in turn to shoulder, neck, low back, noting a little change here, some new sensations there, describing an especially bad stretch last week where pain really ramped up and made sleep impossible. Dr. H listens, nodding along, asks an occasional question about activities, limitations, ebbs and flows. Are you getting out to walk the dog? I know you've been missing that. And so mornings are still the worst, sounds like. As Mr. G's account winds down, Dr. H asks if he's okay moving to the exam table. Perched there, sitting stiffly upright, he listens briefly to his heart, his lungs, works through a series of gentle manipulations of arms, shoulder, turns his head this way and that, murmurs some accompanying questions to the small movements. Is this okay? Right here, that's still where you feel it most. Finishing up, Dr. H steps back, says, so mostly holding steady, I think, right? Good days and bad days, but I don't think we're seeing anything new that's concerning. Mr. G rolls his eyes as he nods and with a sardonic half laugh agrees, good days and bad days, that's one way to put it, but yeah, nothing really new right now. And turning for the first time to the computer screen, Dr. H adds, so let's renew your meds, let's keep doing what we're doing, and I'll see you back in 2 months. Sooner if you need it, if something changes, right? Mr. G nods, smiles as we exit the room. Thanks, Doc, yeah, I'll let you know, I will. As the door closes behind us, Dr. H glances my way and says with a shrug, like I said, not much I can do for him. But I can stick with him. I can keep paying attention, can stay in it with him. Those are the things I can do now. And this encounter, too, stuck with me. Seen in a chart review, Dr. H's time with his patient might look virtually identical to Dr. S's with hers. Follow-up visit with chronic pain patient, medications renewed, no changes to plan. To be fair, the visit length did differ a little bit, but not perhaps as much as one might think. And on some level, both clinicians expressed something very similar, a sense of there being nothing much or more they could do for these patients. And yet the dynamics in those two rooms were so strikingly different. The emotional tenor and rhythm, for sure, keeping a distance, moving quickly in one, versus settling in, taking some time in the other. But perhaps even more critically, more clinically vital, was the way one approach so sharply curtailed communication, largely shutting out the patient's voice and experience and really resisting connection, while the other instead took maintaining connection and centering communication as a worthwhile doing something that could still be offered. Now, ultimately, I want to be absolutely clear. As we've already been discussing, I cannot know what Mr. G or Mr. K felt in terms of their pain experience or others in those visits I witnessed. Though those experiences matter deeply. As an ethnographer, that's not what I can report on. It's not what I can tell you about. I can only report on observable interactional behaviors, not those individual internal experiences. But I do think this sociality is worth taking seriously alongside the attention we rightly direct towards pain subjectivity and, of course, its physiology. I think it's worth studying with care and an eye towards its effect on patients and on clinicians, on elaborating what might be better, more supportive frames, habits, practices, language for what doing something can look like in pain care and what can do more harm. Exploring how steeling against, for instance, is a kind of recoiling from pain's entangling call to acknowledgement, as Veena Das might put it, while sticking with instead enacts a sustaining rather than severing of sociality as itself a worthwhile kind of acknowledgement, a worthwhile kind of doing something. Thanks.
Thank you very much. So I have been working in pain care for over 20 years, and I have an identity as a physiotherapist, but I spend most of my clinical time in interdisciplinary or multidisciplinary spaces with psychologists, medics, dentists, and nurses. My research has really started off in basic science, in a master's course. I then did some public health work, and I landed in this critical social science space with a really deep focus on disability and inequity. And what I'd like to speak to you today is about how we could potentially leverage these insights from social science, and could they make a difference in the clinical encounter. Thinking about this idea of pains, and this is drawn from my PhD work, which really focused on identifying complexity and working with complexity and studying complexity. And so if we think about what people have already referenced about the IASP definition of pain, which is always a slightly useful place to start, I won't repeat it, but we know that there's quite a lot of concepts embodied in that long sentence. But for me, there's additional 6 keynotes, which go on through to talk about how pain is always personal, biological, psychological, and social, that pain and nociception are different phenomena, that life experiences matter, that people's individuals they learn from this wider environment, and that pain serves an adaptive role, but that it can be an adverse one. But despite this complexity hidden in the definition and thinking about pain, we tend to end up with, in practice, this kind of other world where we focus, as we've already heard, on metrics such as pain intensity, pain interference, pain catastrophizing. So splitting up this really complex environment into slightly different and disparate ideas. And so in terms of thinking, I'm going to shift it sideways. So thinking a little bit more about why do we have this pull to take this really massive, expansive idea and narrow it down in order to study and manage it. And that's really the kind of basis of my thinking through this kind of work. I'm just pressing a lot of buttons now. So as a clinician, I think the thing that really struck me was, if all of this is going on, what in the world are we doing in a clinic? Which pain are we talking about when we're managing it? And looking through the social science as a different way of a tool to think about this complexity. So in reality, for us in practice, dualism persists. We still, even though I work in a really big center, very well-resourced, supposedly doing multidisciplinary work, there is still this split. It's either objective, body stuff, or psychological mind stuff on the other hand. So this dualism persists in my observation is when there is little agreement, even within these so-called transdisciplinary spaces, other things come up. And I won't speak too much on the incommensurability problem, because I know the next set of speakers are going to take us through that. But what we tend to see is that professions then take part in activity designed to protect and expand jurisdiction, assert professional authority, claim resources, and protect autonomy. And so we also see this building up of these different categories as a way to bunch up. So, for example, this is psychosomatic, or these are functional disorders. This is psychologically informed practice that we're doing here. This is self-management. And I was curious to really understand what these categories are doing, what is the boundary work that they're doing. And so when there is little agreement, we tend to see that moral injury persists, as we've already heard really nicely from Megan, where some clinicians get really stuck of saying, for example, this is an extract from an interview with a pain consultant. We know that patients expect more from medicine when it's able to deliver. There's systematic reviews showing that, and I think that's particularly the case. Experience would show anecdote for people living with pain. I mean, you would think, wouldn't you? You'd be able to get rid of it. No, and it's how many patients told me that. We can do heart transplants. Why can't we get rid of my pain? And so in response to that, I drew on this concept of multiple ontologies, and apologies, it's going to get fairly technical in the social science, and practicing my ability to communicate to a slightly different audience. So what I did is I took a whole bunch of interview and observational, ethnographic observation data, and came up with what was showing up in this kind of work. And in order to make sense of it, I found that no one particular theory was helpful in help me make sense of the whole package of things. So I turned to multiple ontologies, which really, as described by Scott Graham, is that the theory of multiple ontologies describes differently situated material activities that produce different objects. And the reality you engage in is determined by the kind of actions you habitually perform and the material context in which you act. He was, of course, extending the work of Anne-Marie Moore, and the focus here is that reality is what is done. So multiple ontologies for me are multiple realities that are constructed through doings or practices, and doings can take many forms and interactions, which was very much what my data was showing me. And so we identified through Graham's 1, 2, 3, 4, 5, 6. You'd think I'd know this by now. He had 6 ontologies that he identified. And from my empirical work using these qualitative methodologies, I focused on those instances of practices and what showed up about pain management or pain care that was narrated by my participants and as observed and interpreted by me. So these, I'll go through these in a little bit more detail, but I will give you the top heading, which is what Graham called them, and my interpretation beneath it. So the first one that showed up in this kind of multiple ontologies was a semiotic, biomedical, or traditional ontology. This was very much that pain signifies an underlying disease and works really well for acute presentations. The second one was a biochemical or biomedical contemporary ontology, which was really about neural pathways, the neuron doctrine really present in our parallel meeting that's happening down the road. And this aligns with conditions known about biological processes. So there's something in the microscope that will really tell us what is really going on here. The next one was more of an empirical but discursive ontology. This is that statistical ontology we keep hearing about, p-values. And we give people questionnaires and we narrow it down and then we group them up into lovely little numbers. And so these are known to be really good on a population level and good in clinical trials, less helpful in clinical practice. What we do see in clinical practice is more of this ontology. Based in cognitive psychology, the cognitive behavioral ontology really focuses on the psychological impact of pain. And this is really about standardization, protocols, fidelity, and it's commonly aligned with specialist pain services because we offer programs that are designed to deal with what's going on here. And then a non-modern practical one that Graham talks about was really about multi-professional and multiple disciplinary working and boundary work. Now, the issue with this one is it wasn't really present in my data, even though I was working in a space that purported to do this kind of work. It really was missing, as we've already heard. And then there was this other non-modern, more discursive ontology that felt a little bit more about phenomenological narratives, person-centered care. But this, though present in patient-facing materials, felt very idealistic and rhetorical. It was something that was supposed to be happening, but in real life, there were some questions. And there was a couple of other ontologies that Graham didn't identify, but that I did in my own work. And this was a biomechanical identity that we've already kind of heard about, and this other thing embodied into subjective work that was going on. And this is not a totality. This is not the total number of ontologies present, because as this theory allows is that there's continuing ontological change and multiplicity. And so when we're thinking about expanding on that, the body as a machine, ontology, I won't go into that, but spend a couple of seconds on the embodied intersubjective ontology. In this kind of practice, uncertainty was held. It was not diagnosis-focused. It was comfortable with mysteries and unknowns and doubts, and it was movable. And this was happening outside what I call thought silos. So this was more in social prescribing settings. Some general practitioners, policymakers really embraced this, and disillusioned practitioners. So people who were thinking, my work is not good, but if I think otherwise, that really helps me out. So what does this mean for the clinical encounter? For me, in an informal experiment, really, I've been trying to see if I could work with these multiple ontologies in a clinical setting, because patients show up with their own different realities, and rather than me trying to oppose them or tell them that what their reality is not real, using these kind of frameworks allows me to work with what shows up. With a caveat, pretty big caveat, that it's not a free-for-all. It could be, but I'm sure clinically and professionally I would not be allowed to practice that way. But if I think of a single case, for example, someone experiencing back pain, if they come in with a very biomechanical ontology, it is within my gift to work with that. I don't need to question them. I can do some work with that. If they kind of think, oh no, this is more something to do with my humors and my spirit, I can also work with that. Mainly because the evidence base does not tell us that anything that we do is superior to what they are showing up with. So the things that we have to consider is to validate that person's experience in reality and to discuss available options within their particular context and circumstances. So if I have access to refer them to a service that provides care that's more ontologically aligned with what their reality is, I can do that. But it involves conversations about availability. Is the thing that they think exists available or feasible within, for us, the National Health Service? So things like acupuncture, for example, might be available if you had a certain diagnosis. The feasibility, if there were financial constraints to accessing this, so is spending a little bit more time signposting or working in an advocacy setting. Crucially, we have to assess risk, because there are practitioners out there who might not have the best interests of our patients at heart. That is something that I think researchers could really contribute to. How do we look at risk in a situation when we don't have any single particular truth or reality? And also preventing harm, because we know that if somebody gets stuck in a cycle of doing things that do not work, big commas, then that could potentially cause harm. But the harm literature rarely addresses these kinds of difficulties when thinking about a single encounter. And ethics, very excited about bioethicist, because this is something that would allow us to make these decisions on a moment-to-moment basis. Is this ethical practice if I suggest something that I might not particularly think? For example, I am not a religious person, but if somebody has strong religious views, how can I support them ethically so that they have that ontologically aligned care? And like I said, my professional boundaries. And I conclude by thinking about possibilities, rather than the disagreements that we've seen when things don't kind of match up. Multiplicity for me in a clinical encounter allows me to work with my professional colleagues who I might really disagree with in terms of how they're phrasing things, but if I go through that kind of list with me, it makes it a little bit easier to work with a whole bunch and a broader bunch of disciplinary perspectives without needing to take the high end. And I can embrace complexity both in theory as well as practice. So these sites of continuing ontological change for me offer real possibilities within the clinical encounter. And I would like to thank my supervisors for this kind of work and leave it open to questions. Thank you.
Good afternoon. Today, I want to re-examine a familiar story in both hypermobile Ehlers-Danlos syndrome, or HEDS, and rare disease care, and that is one that sees the diagnostic journey as the central narrative and diagnosis as the long-awaited resolution in the context of our topic today, thinking and talking about the patient and the clinical encounter. The diagnostic odyssey, which is commonly discussed in rare disease communities, aims to put a name to the often lengthy and challenging processes that individuals with rare diseases undergo to receive an accurate diagnosis, and it is no doubt an exhausting journey. HEDS patients in particular are often dismissed, misdiagnosed, or even told that their symptoms are psychological. However, my research suggests that the clinical encounter doesn't end at diagnosis. In fact, the diagnostic moment reveals a deeper problem in how care is communicated, coordinated, and imagined between the patient and the provider. Over 4 months of ethnographic research with HEDS patients, I explored what happens after diagnosis. What kinds of conversations take place, and more importantly, what kinds don't. I found that for many, diagnosis is not the beginning of coordinated care, but a rupture, a moment of abandonment rather than continuity. And I term this phenomenon being diagnosed and dumped, as one of my interlocutors quoted it. Before going further into this presentation, I do just want to give a brief overview on what HEDS is, just to give a bit more context. Hypermobile Ehlers-Danlos syndrome is a connective tissue disorder that affects collagen production, which is basically the glue that holds your body together. And when it is faulty, like it is in HEDS, this can lead to wide-ranging symptoms for patients. And importantly, we need to note that each person with HEDS is unique. However, a requirement for diagnosis is that patients experience chronic, widespread pain for longer than 3 months, making HEDS first and foremost a chronic pain condition. For nearly all HEDS patients, the diagnostic moment is extremely emotionally and also practically charged. It is the culminating moment that reveals that their suffering is real after years of negative experiences in many cases. Clinically, it might look like a resolution, but practically and relationally, it is often much more complex. Sociologist Anne-Marie Judel reminds us that diagnosis is not only a classification, but a moment when the stakes are extremely high for the patient. She writes, "Indeed, diagnosis is so pivotal to Western medical practice that it is hard to imagine medical care without it. The diagnosis gives us a sense of certainty and an idea of what way our disorder, disease, or discomfort will evolve. Somewhere, every request for a diagnosis is a kind of request for a story with a happy ending, or at least a comprehensible one. In the clinical encounter, then, we can see how patients often would hope for a sort of similar narrative arc that Judel describes, a beginning of care, not just a name. But for many of my interlocutors, as well as for myself, the diagnostic encounter stalled at that naming moment. One participant recalled, "I was diagnosed by a rheumatologist that my neurologist sent me to for a second opinion after he suspected EDS. The rheumatologist told me I do have it, but it's the same thing, that he doesn't need to see me again because they can't do anything about it." A member of one of the Facebook groups I observed during field work shared something similar, saying, "The guy who diagnosed me literally said, 'Well, nothing we can do about it. Sorry.' No pain meds, no PT, nothing. Just a diagnosis and out the door." In these clinical encounters, the diagnostic moment becomes an ending of attention, of care, of dialogue, when it is clear that patients, especially those with chronic conditions like HEDS, most need sustained relational engagement. And this is what I aim to encapsulate with my concept of being diagnosed and dumped. Diagnosis in these cases fails to act as a bridge to care. Instead, it becomes a handoff to nowhere, often back to the self. This also reveals a troubling issue, I think, in how the medical system conceptualizes responsibility after diagnosis. As it is a connective tissue disorder, HEDS sits uneasily across multiple specialties, like I think we can see in a lot of complex chronic conditions. Rheumatology, neurology, gastroenterology, pain management, and more might all be involved, but no single provider claims ownership of the full picture. And the result is a fragmented clinical experience, one where patients are endlessly referred but never truly cared for. One participant put it quite plainly, saying, "Genetics diagnosed me with EDS and pretty much said, 'You're good.' And then I went back to the rheumatologist who said, 'You're good, not my problem,' basically." The diagnostic encounter, rather than initiating an integrated care plan, often ends with this kind of dismissal for most of my interlocutors, leaving patients in limbo. My research suggests that the diagnostic encounter must be understood as a relational moment, not just the act of naming, but a turning point in care. And when that relationship breaks down, the effects are often lasting. One participant described how the diagnostic encounter left her feeling both validated, yes, but also betrayed. She said, I had to do so much work on my own and push so hard just to still be in the same situation where I have to completely self-manage. The diagnosis was validating, but it was also frustrating. I almost wished that it was something else because I would have been able to get actual treatment. And instead, it was like, okay, great. Now I know this is real. This is why I've always felt different and felt like something was wrong with me. But now I have to continue trudging through the mud and self-management and doing all the things on my own. In the absence of clinical follow-up, HEDS patients build their own care communities, particularly in very extensive online peer networks where I did a lot of my ethnographic fieldwork. In these online peer networks, information management strategies and emotional support circulate almost nonstop. It's pretty much 24 hours a day. And arguably, these communities take on a role that should begin in the clinic. It appears that the problem isn't just a lack of service for patients, it's a breakdown in how the clinical encounter is imagined and enacted. Diagnosis is treated as a closure rather than a conversation. So, what would it mean to reimagine the diagnostic moment not as the end of a linear journey, but as the beginning of a relational one? First, we must ask clinicians to see diagnosis as an invitation to ongoing dialogue, to care planning, and to patient-provider collaboration, or as anthropologist Anne-Marie Moll terms it in her book, Care in Practice, a willingness to tinker, a willingness to play around until we find what works. That means offering referrals, yes, but also giving patients tools, options, and simply hope rather than these sort of abrupt endings. This can include referrals to pain specialists, physiotherapists, autonomic disorder clinics, guidance on self-management, mental health support to manage the emotional burden of having a chronic illness, or simply connecting patients to these online peer support groups. And critically, especially within the context of HEDS, clinicians need training not just in the diagnostic criteria and how to reach that label, but in what care can look like after diagnosis. Even if HEDS isn't curable, it is livable. And that message should be a part of the diagnostic encounter itself. So to conclude, the story of HEDS care is not just about how long it takes to get diagnosed, it's about what kind of care patients receive or don't receive after that moment. The idea of diagnosed and dumped highlights a gap in the way that care is often structured, less as a failure of medical knowledge and more a challenge in sustaining relationships after diagnosis. By approaching the diagnostic encounter as the beginning of an ongoing conversation, and perhaps even integrating a bit of this tinkering into the clinical encounter, we can start to build more continuous and supportive care for people with HEDS and other complex chronic pain conditions. Thank you.